Bismillah ar-Rahman ar-Rahim, wa-salatu wa-salam ala Rasulillah. In the beginning, I would like to thank specifically Dr. Ibrahim al-Shahrani, Dean of College of Dentistry, King Khalid University, for his invitation. Also, I would like to thank the organizing committee, the scientific committee, and everybody who worked in this nice event to have it in a very nice way as it is. I'm really honored to be here among you. It's my first time in Abha city. I love it. It's a very nice city. And
it's coming, Doctor.
Okay.
Yes. Sorry for that. Unavoidable technical problem.
Okay, no
but
problem.
It's coming.
No problem.
Sorry. Excuse me, doctors. They are fixing now. They are fixing. We're going to start right now. Thank you. Within less than 1 minute, we're going to start. Sorry, Dr. Nabeel. Okay, we are ready. Thank you.
This is what happens when you have a double dose of orthodontics. It's a lot of orthodontics for the morning, so the computer overheated, so. بسم الله. يعطيك العافية. Okay. Today I'm going to talk about treatment of dentofacial deformities, and I thank Dr. Dolci for his very nice presentation. We're going to talk about orthodontics in a different field, which is the treatment of dentofacial deformities from an orthodontist perspective. You know, treatment of dentofacial deformities, it takes a teamwork, orthodontist and a maxillofacial surgeon working together in treating these cases. When we look at skeletal problems in 3 planes of space, we can see that we can have a skeletal class 2, a skeletal class 3 in the anteroposterior dimension or the sagittal dimension. We can have posterior skeletal crossbite and skeletal asymmetry in the transverse dimension. Now, when we look at the vertical dimension, we could have vertical maxillary excess, or what we call VME, high angle cases or low angle cases, or we could have a combination of all of these in 3 planes of space. So what are the orthodontic treatment options for skeletal problems? We can do growth modification. However, we have to have the patient growing in order to do growth modification. Usually, growth modification is very useful in mild to moderate skeletal problems. We can do camouflage orthodontic treatment, basically accepting the skeletal relationship, the mad relationship of the skeletal jaws, and we do the dental movement in order to accommodate the skeletal abnormality. Again, we can do camouflage orthodontic treatment in very mild to moderate skeletal problems. Now, when it comes to severe skeletal problems, we have to consider orthodontic, orthognathic surgery. So what are the indications for orthognathic surgery? It's the severity of the skeletal and dental malocclusion, and when growth modification cannot be achieved, and when there is aesthetic and psychosocial consideration. When we look at the history of development of orthognathic surgery, before the 1950s, surgeons, they used to do osteotomy, which basically in skeletal class 3, due to mandibular prognathism, they used to take part of the mandible off. So, and that created really severe problems. In the 1954, Caldwell and Litterman, they developed the vertical ramus osteotomy technique, followed by, in 1957, with the bilateral sagittal split osteotomy, which made the procedure very manageable and very simple, low risk, and it popularized the using and doing orthognathic surgery. In the late 1960s, Lee-Fort maxillary surgeries were introduced, and all of you know that we have three types of Lee-Fort surgeries. We have Lee-Fort 1, Lee-Fort 2, and Lee-Fort 3. It depends on the level that you do the osteotomy for the maxillary surgery. In the late 1970s, double jaw surgery was very popular, which improved the stability of the results of these cases. In the 1990s, rigid fixation was also introduced, which reduced the relapse of these cases and improved the stability of the orthognathic cases. In the 2000, distraction osteogenesis became popular, and it is mainly used for severe cases with anomalies. When we look at the orthodontic camouflage treatment of skeletal class 2, what are the options that we have? We can extract upper first premolars and finish molars in class 2 relationship. Now, I want to share with you thoughts, because some orthodontists, they would use heavy class 2 elastics in the treatment of these skeletal class 2s. And we don't advocate really using class 2s as a treatment modality. We advocate using class 2 elastics as a finishing tool rather than as a treatment option. Because class 2 elastics, they would have the following effects: extrusion of mandibular molars, the mandible will rotate backward and downward. The extrusion of maxillary incisors would result in an excessive gingival show upon smiling, or what we call gummy smile. Flaring of the mandibular incisor would pose some unstable results and would cause more recessive chin in a skeletal class 2, which would affect the soft tissue appearance and the profile of the patient. Also, the rotation of the occlusal plane with class 2 elastics is also unfavorable in this case. So we don't use class 2 elastics as a treatment modality again. We use it as a finishing tool. So long time of class 2 elastics use is not recommended. Now, the orthodontic camouflage treatment of skeletal class 3, when we have mild skeletal class 3 or class 3 tendencies, the mandibular first premolars extraction is not a good option for the following reasons. Usually, the lower incisors are retroclined to start with as a form of compensation for the skeletal-man relationship. And retraction of lower incisors in a skeletal class 3 will leave the chin more prominent. So you are deteriorating the soft tissue profile of the patient. The molars will finish in a class 3 relationship, which basically a molar against a premolar, which is to us considered to be a traumatic occlusion. In a mild class 3 occlusion, we can extract lower first premolars and upper second premolars. And then we can finish the case in a class 1 canines, class 1 molars. When it comes to timing of orthognathic surgery, usually it is done when growth is completed. And how do we assess completion of growth? We assess completion of growth by doing several techniques, either by doing superimposition of a serial cephalometric radiographs, or by taking a hand and wrist radiograph where we can look at certain bones in the wrist of the patient And you know, we have the epiphysis and the diaphysis. If we have fusion between the epiphysis and the diaphysis of the long bone, then the growth is completed, then the patient, for us, is considered ready to do the orthognathic surgery. Now, in very few situations, surgery can be performed during growth, and this based on certain indications. When the deformity is causing severe psychosocial problems, and or when you have compromised functions such as breathing and chewing. Now, as I said, treatment of these skeletal deformities, it takes a teamwork. The orthodontist has to work closely with the maxillofacial surgeon. So basically, after the treatment plan is set, the orthodontist would sit with the patient and would discuss the orthodontic part of the procedure, and the maxillofacial surgeon would sit with the patient and discuss the surgical part of the procedure and all the risks associated with that procedure. And once the decision and the agreement has been reached, then the orthodontist would start the pre-surgical preparation part. So a few slides about the selection of appliances for these cases, for these surgical cases. It has to be a fixed orthodontic appliance. It should allow rigid stabilization. Brackets should have hooks for intermaxillary fixation. Surgical hooks on the stabilizing arch wires are preferable. So you could have brackets, premolar brackets, canine brackets with hooks, and also in addition to that, you could have surgical hooks, which are crimpable hooks that you put on the stabilizing arch wire. Removable and lingual appliances are not recommended for orthognathic surgical cases. Plastic and ceramic brackets are also not suitable, so it has to be metal brackets. We can use both 18-slot and 22-slot edgewise brackets, no problem. Basically, the orthodontic preparation, you have to progress through your arch wires. So you start with light wires until you reach what we call the stabilizing arch wire. This stabilizing arch wire you want to leave for 6 months before surgery. Why do we leave it for 6 months before surgery? Because you don't want to have any type of tooth movement that would interfere with the surgical correction that the surgeon would do, or with the occlusal splint won't fit anymore during the surgery, and that would pose some complications during surgery. So the stabilizing arch wire that we recommend in an 18-slot is at least 1622 stainless steel. The stabilizing arch wire at least should be 2125 SS or stainless steel or TMA in a 22 slot. So as you can see, the stabilizing arch wire is a rigid rectangular stainless steel arch wire that the surgeon would use during surgery for proper orientation and intermaxillary fixation during the surgical procedure. The appliance should have molar band cemented. We don't recommend putting buccal tubes on the molars because you don't want these buccal tubes to fail during the surgery, and that would create also problems for the surgeon during surgery. We should have brackets, headgear tubes on the maxillary molars, auxiliary tubes on the maxillary and mandibular first molars, and we should have lingual cleats on the molar bands. We always recommend that you band mandibular second molars. Now, banding maxillary second molars is not as important as banding mandibular second molar. Sometimes when we band maxillary second molars, that would cause some interferences, okay? And it takes a very long time to align and to torque these maxillary second molars. So banding mandibular second molar is a must. So how do we position the brackets in these cases? Basically, we position them as any conventional orthodontic case. However, sometimes the surgeons, they have to go in between the teeth, in between the roots, and they do osteotomies in between the teeth. So in these cases, you have to place your brackets accordingly in order to diverge the roots away to make the life of the maxillofacial surgeon easier. And then after the surgery, you can reposition the brackets back in order to have proper alignment of these teeth. The first phase of orthodontic preparation for orthognathic cases, alignment and leveling, and we call it decompensation. You know that in skeletal class 3 and skeletal class 2 cases, there are some compensations that happens to the incisors. And usually we have to decompensate these movements of these incisors. Usually the decompensation should be carried out by tipping movement of these crowns to their proper positions. So we have to use light, round arch wires. We don't start with rectangular arch wire, and now with the presence of rectangular night-eye arch wires, it is tempting for some orthodontists to start with these night-eye arch wires from the beginning, okay, where you are introducing torque, root movement at that early stages of leveling and alignment. So we don't recommend that. We recommend that you start with very light, round arch wire, and it should be undersized round arch wire in order to have the forces very low and low friction. Bodily movement at that stage is not desirable. So in skeletal class 2, what are the compensation that we see? We see that usually the maxillary incisors, they are in a proper position, and the lower incisors, they are trying to meet the upper incisors. So they would procline anteriorly in order to reduce the gap or reduce the overjet as a form of adaptation, okay, a natural adaptation. So we have to decompensate that. So how do we decompensate that? By retracting the lower incisors back, and usually in these orthognathic skeletal class 2 severe cases, we extract mandibular first premolars only. To retract the lower incisors, that would increase the amount of overjet, and then the surgeon would, then you would allow the surgeon to maximize the advancement of the mandible forward. So in skeletal class 2s, usually we extract mandibular first premolars. In skeletal class 3, again, we have a form of adaptation or compensation where you have proclination of the upper incisors and retroclination of the lower incisors, where they are trying to meet each other for a better mastication of the patient. However, in severe cases, these incisors, they don't meet each other. But the inclination of these incisors as a form of compensation has to be reversed. So you have to do decompensation of these cases. So what's the decompensation that we do in skeletal class 3? Usually we have to retract upper incisors, maxillary incisors, and this may require premolar extraction in the maxillary arch. So in skeletal class 2, we extract in the mandible. In skeletal class 3, we extract in the maxilla, and we don't extract in the mandible. And again, this will increase the overjet, and this will make the case worse, okay, and then the surgeon would go in and do the jaw movement. Arch coordination at the end of the orthodontic preparation is extremely important. Now, in skeletal class 2s, we can ask the patient to move the jaw forward, okay, and check the arch coordination, no cross bites in the posterior segment, and everything is fine, so then the patient is ready to go for surgery. So if you found difficulty in this movement or asking the patient to advance the mandible forward, then you can basically just remove the arch wires, take an impression, and do a working models, and then check the arch coordination. And this is what we do in skeletal class 3. In skeletal class 3, you cannot ask the patient to move the jaw back, okay? So basically, you have to take the working models as an orthodontist and make sure that you have arch coordination. Now, what are the pre-surgical records that we need, okay, for these cases? We take panoramic radiograph. We should have a cephalometric radiograph, study models. We take intra and extraoral photographs, and we take dental cast for model surgery. And usually these are taken by the maxillofacial surgeons. The panoramic radiograph, basically what we do is we check root positions, root proximity to each other. Now, again, if the surgery is indicated for osteotomy or segmental osteotomy between the roots, then you have to make sure that you have at least 4 to 5 millimeter of root separation. And also we check for the presence or absence of any pathological conditions. The radiograph can be supplemented with any periapical radiograph. So the panoramic radiograph would give you an overall overview of the dentition and the supporting structures. The cephalometric predictions and model surgery for these cases, usually the cephalometric predictions should be done before model surgery, because you can have an idea about the numbers of the movements that you're going to do from the cephalometric predictions that you can convert into the model surgery that you will do. Usually these predictions can be done by the cephalometric predictions can be done by the orthodontist and the surgeons together. However, the model surgery, it is done by the surgeon. Now, sometimes the surgeons, they have to do face-bow transfer, okay, to mount these models for model surgery. And it is extremely important in cases of maxillary surgery, impactions of maxilla and auto-rotation of the mandible and double jaw surgery. So face-bow transfer is extremely important before mounting these models. We can do the computer predictions. There are certain softwares that we can use, okay, to do the VTO or the visual treatment objective. Basically, this is a patient who came to the clinic complaining from orthognathic mandible. We took his photographs and cephalometric radiograph, and we did the computer prediction for a mandibular setback. And we can share these photos or these predictions with the patient. However, we don't recommend that, especially in very severe cases, because when you show and share those predictions with the patient, then you are committed to giving the results that you show to the patient, okay, at the end. And if you cannot deliver that, then it is better off not to show the predictions. It is good for your own reference, okay, and not sharing it with the patient. The model surgeries that are carried out by the maxillofacial surgeons, basically they are important to verify whether the surgical movements are possible or not. Also, they are extremely important for the fabrication of the surgical splint. Now, the surgical splint is used during the surgery for the orientation of the upper and the lower jaw before the rigid fixation. And also, the mounting of these models, also it is important for occlusal interferences. Sometimes the surgeon would do some selective grinding on the models. They would mark the areas that they did the selective grinding on the models, and they would duplicate that during the surgery if they found any interferences. And most of this selective grinding that is carried out by the surgeon in the surgery, involves the maxillary second molars, and especially the maxillary lingual cusps of the maxillary second molars, which cause interferences with the movements. Now, this is an example of the model surgery on an articulator. The surgeon would move these models, okay, according to the movement that he wants to do, whether it is maxillary impaction, advancement, mandibular setback, and so on. And they can do measurements of how much of movement they're going to do. And after they do the model surgery on the articulator, then they would fabricate the occlusal splint, as you can see on the lower right hand side. And usually these occlusal splints, they are made up of hard acrylic, and they should be made of as thin as possible, basically just for orientation during the surgery. This is an example of an occlusal splint in surgery. And as you can see, after the surgeon did the bilateral sagittal split osteotomy, he set back the mandible back, and then he used the occlusal splint for orientation. And as you can see, the surgeon is using our appliance, the orthodontist appliance, which is the fixed appliance with the surgical hooks for intermaxillary fixation during the surgery. Now, post-surgical, after the patient goes into surgery, there is a program or a guideline for follow-up appointments with the orthodontist. Basically, 1 week, you can check the occlusion of the patient, splint and appliances. 3 to 6 weeks, we can reinitiate orthodontic treatment after the range of motion has been re-established and stability also achieved. We can remove the splint. Sometimes the patient, they come at that appointment with the splint already removed by the maxillofacial surgeons. And the role of the orthodontist at this stage is basically to change and remove the stabilizing heavy rectangular arch wires and basically just put light arch wires and start vertical elastics. And usually the treatment, post-surgical treatment would take 4 to 12 months in an ideal situation or environment with an average of 6 months. Okay. Now next I'm going to share with you a couple of cases which I thought they are interesting. You're going to find out that all of them are skeletal class 3. And the reason for that is that skeletal class 3 here in Saudi Arabia is very common. It is a common problem. The percentages or the prevalence of skeletal class 3 in Saudi Arabia can go 7 to 10%. So from every 100 patients that you see in your clinic, you would expect to see 7 to 10 of them to have a skeletal class 3 problem. So it is an extremely common problem, and this is why I'm going to focus on the treatment of skeletal class 3. This is Saad. He came to the clinic, to the orthodontic clinic at the College of Dentistry, King Saud University, complaining from a protruding or prognathic mandible. Upon extraoral examination, the frontal examination revealed that the patient has some skeletal asymmetry too, with deviation of the mandible to the right side and increase in the lower face height. Now, looking at his frontal smiling photograph, we can see the narrowness of the maxillary arch and increase in the buccal corridors or the negative space that we call, okay? Now, looking at his soft tissue profile, we can see that the patient has a concave profile with retrognathic maxilla and prognathic mandible. Intraorally, we can see that the upper maxillary arch is constricted. It has a V-shaped arch with an asymmetry both in the transverse and the anteroposterior dimension, with mild to moderate crowding in the maxillary arch. When we look at the mandible, we can see that the patient has mild crowding with a U-shaped arch form. Now, the right buccal segment reveals that the patient has a class 1 molar, class 3 canine relationship. On the left side, he has a full class 3 molar relationship and class 3 canine relationship. Anteriorly, he has a skeletal open bite, and this reflects in the increase in the lower face height with deviation of the mandible to the right side, and this represented by the skeletal asymmetry that he shows extraorally. So we have a deviation of the mandible to the right side associated with mandibular midline deviation. So it's a skeletal class 3 due to maxillary combination of maxillary retrognathism and mandibular prognathism and skeletal asymmetry and skeletal open bite. So this is considered to be a severe case that would require an orthodontic orthognathic surgery. So this is the patient. We decided to extract maxillary premolars, in this case to decompensate him. And at this stage, he's ready for surgery. The stabilizing arch wires, I use 18 slot. So basically, we have 1622 rectangular stainless steel arch wires in the upper and the lower. And as you can see from his soft tissue profile, the severity of the problem has been increased, and the patient has been warned from the beginning that if you decide you want to go with this option, that the severity would look, the case would look worse before surgery. And as you can see, the prognathism looks worse because of the decompensation that we did. Still, he has the deviation of the mandibular midline and the skeletal asymmetry. And here's the patient after surgery. Basically, the surgeon went in, did maxillary impaction because he had vertical maxillary excess and downward backward rotation of the mandible. So the surgeon did impaction, okay? And when you do the impaction, usually the maxilla would advance by itself because of the anatomical orientation in this region. So did an impaction, the mandible would auto-rotate forward, then the surgeon would go in and do mandibular setback. As you can see here, what's important for us, as Dr. Dolce mentioned, the class 1 canine, okay? We always want to check the class 1 canine relationship. Now, the molars are class 2 in this case, which is okay to finish molars in class 2 because the teeth, still you have molars hitting against each other, okay? So class 2 molars, class 1 canine, maxillary impaction with advancement and mandibular setback. So here's the patient, again, comparison of the pre-surgical extraoral photographs and the post-surgical extraoral photographs. There is a great improvement in his soft tissue profile. Now, looking at his nose, usually we do the nose on a second phase, okay? We don't do it at the same time doing the maxillofacial surgery, okay? And some surgeons, they would go in and do everything in one shot, okay? No, we'd like to leave the nose for a separate stage. We leave the tissues, the soft tissue adaptation to take its role, and then we consider looking at the nose and doing the rhinoplasty. And here's the patient after debonding. And you can see that we have a good alignment of the upper arch, lower arch, and we have good intercuspation. Class 1 canines, class 2 molars, the midlines are centered. This is Saud. Again, he came to the orthodontic clinic at King Saud University, complaining from a prognathic mandible. Looking at his soft tissue profile, again, he has a prognathic soft tissue profile with a concave appearance. Looking intraorally, we can see in this case that the upper arch is well developed. It's a U-shaped with some mild to moderate spacing. In the lower arch, we can see that the patient has some mild crowding. Now, looking at the buccal segments, the patient has a full class 3 molars and canines with an anterior crossbite, which is reflecting the skeletal class 3 appearance. Now, this is before going to surgery. Again, we did the leveling and alignment. We did the decompensation by just basically proclining the lower incisors. In the upper arch, we did not extract premolars in this case because the patient had spacing, okay? He did not have crowding. So basically, a non-extraction case. And this is the computer predictions that I showed you before. After discussion and case analysis with the maxillofacial surgeon, we decided to do it a one-jaw, single-jaw mandibular setback. And here's the surgery, and you can see the osteotomy location, the bisagittal split osteotomy done by the maxillofacial surgeon under general anesthesia. And here the surgeon has the osteotome in the split area where he's basically splitting the mandible. And here's the split osteotomy completed by the maxillofacial surgeon. And after completing the split osteotomy, the surgeon would use the occlusal splint and do the intermaxillary fixation before he goes in and does the rigid fixation, which means plates and screws. And here's the patient following surgery. So in this case, basically what we did is a single jaw mandibular setback procedure. And looking at his soft tissue profile, he is more towards a straight soft tissue profile as compared to the prognathic soft tissue profile he came with. Looking intraorally, you can see that we have achieved class 1 molars and canines in this case, and we've corrected the anterior crossbite that was associated with the mandibular prognathism. Here's the patient before and after. The third case is Hassa. Also, she came to the clinic complaining from prognathic soft tissue profile. She felt that her lower jaw is protruded. She felt that she has flatness in the maxillary arch region, in the zygomatic infraorbital region. So after evaluation of the case, it is a severe skeletal class 3 with increase in the vertical dimension. So basically, it's an indication for orthodontic, orthognathic surgery. It's not indicated for any type of camouflage treatment, okay? Now, upon examination, also looking at her frontal photograph, we can see that there is increase in the vertical dimension, incompetent lips, smiling, constriction. Also, we can see the constriction in the maxillary arch and increase in the buccal corridors and the negative spaces. Looking at the soft tissue profile, we can see retrognathism in the maxilla, prognathism in the mandible. Looking intraorally, she has a U-shaped, well-developed arch form. However, she has missing tooth number 1.6, and the 1.7 has already tipped into that space. In the lower arch, she has missing tooth number 3.5, and she has generalized spacing in the lower arch. The buccal segments, definitely she's a class 3 with a skeletal open bite, okay? And also in this case, we have deviation, slight deviation of the mandible. So in addition to all of these problems, we have the skeletal asymmetry in addition to that. So this is what makes us consider the option of doing orthodontic, orthognathic surgery. Looking at her cephalometric radiograph, we can see by looking at the morphology without having any numbers. Okay, we can analyze this cephalometric radiograph, but I just want you to appreciate the morphology of the mandible. In vertical cases, you would see the body of the mandible is long, the posterior ramal height is short, and you would see the backward downward rotation of the mandible. And if you look at the morphology of the maxilla, you feel that the maxilla is hypoplastic, both in the transverse and in the anteroposterior dimension. And this reduction in the amount of tissue in the maxilla is not only at the dentoalveolar level, it is also goes up to the infraorbital and the zygomatic region, as I mentioned. So here's the patient after a double jaw surgery. Basically what we did with the maxillofacial surgeon, maxillary advancement, a mandibular setback, impaction of the maxilla. You can see that the buccal corridors has been reduced. Okay, she has a better soft tissue profile. Now intraorally, basically we opened up a space for tooth number 3.5 to receive an implant. And we have achieved a super class 1 molar relationship and class 1 canine relationship. The upper and the lower midline, they are coincident in this case. You can see this is the panoramic radiograph, and you can see the mini screws, the screws and the plates for rigid fixation, and you can see the space for tooth number 3.5 for implant replacement. Now this is the patient before treatment and the patient after treatment. And you can see the great improvement in her soft tissue profile. She's extremely happy. She's a new person, okay? And she's highly appreciative of what has been done. This is the intraoral photographs before and after. So not only we improve soft tissue profile and aesthetics, we also improve the occlusal relationship where we give up the patient better function, better mastication. Case number 4, this is Muhammad. Also he came to our clinic complaining again of skeletal class 3. Now this is a more severe kind of a case. Looking at his frontal facial photograph, we can see also he has increase in the lower face height and some sort of facial asymmetry. Looking at the intraoral frontal, we can see that there is constriction in the maxillary arch, black corridors, same picture, same scenario, but it is a more of a severe case. The profile, it's a prognathic increase in the lower face height, severe incompetency, lip incompetency in this case, because of the vertical increase in the vertical dimension. When we look at intraorally at his occlusion and his dentition, the upper arch is basically a V-shape upper arch with totally blocked out tooth number 2-5, okay, and with asymmetry both in the transverse dimension and in the antero-posterior dimension. So severe crowding in the upper arch, mild spacing in the lower arch, and this is the classical picture in these severe skeletal class 3 because they have prominent mandibles, so the teeth, they have enough space to be aligned. The maxilla is constricted both in the transverse and the antero-posterior, then you would see crowding. So in this case, and also if you look at the buccal segments, class 3 molar canine relationship, lateral open bites, anterior open bites, so skeletal open bite, so it is considered to be a severe skeletal class 3 open bite case. So we decided to extract upper premolars in this case, and this is the patient before going into surgery. We extracted upper first premolars. We extracted the blocked out premolar and the first premolar on the other side. Now, in this case, we placed stainless steel crowns as a temporary measure during our treatment, and then those would be replaced later with a permanent crown replacement. So here he has the stabilizing arch wire, which is a 1622 rectangular arch wires, and with the surgical hooks, he's ready to go for surgery. So the plan of surgery, again, maxillary impaction, advancement, auto-rotation of the mandible, and setback of the mandible. So it's a definitely a double jaw surgery. Now here's the patient 2 weeks after surgery, and as you can see, the patient still has some swelling, okay? Swelling in the maxillary infraorbital region, which is kind of normal, and usually the swelling would disappear within a month after surgery. And you can see, I don't know if it is clear, he has still the sutures in place. So we saw the patient at that stage. Here's the patient before treatment and after surgery immediately. And you can see the big improvement in the anteroposterior soft tissue profile of the patient. Still the patient has some lip incompetency. And as we proceed on, and this is the intro, just to remind you of the intraoral photographs of the way he looked intraorally. And this is the way he looks after some time into post-surgical orthodontics with class 2 elastics and vertical elastics in order to settle the occlusion. The midlines are coincident in this case. Again, class 1 canines, class 2 molars. And here's the patient a couple of months after surgery. And as we go along, the swelling of the face would subside. Even the soft tissue profile would improve with time. Okay, so you need to be patient when you look at these cases. Just give it time. The swelling will subside, the soft tissue, you have better analysis or better view of the correction, soft tissue correction that has been done. Okay, the patient, if you look at his soft tissue profile at this stage, it's a straight soft tissue profile. Even the lip competency has been improved in this case. So we can do a lot with orthodontic, orthognathic surgical options in these severe skeletal problems. Lastly, I want to share with you a few comments about the psychological effect of surgery, okay? Because sometimes these patients, they would undergo some psychological impact following surgery. Studies shows that 80 to 90% of these patients, they would report satisfaction, long-term satisfaction of the results. A similar percentage would recommend procedure to others, and they would do it again. Now, when we look at the psychological well-being, okay, of these patients, as shown by Prophet in 2003, you can see there is a line which is dividing the psychological well-being from being high and low, okay? Now, before treatment, pre-treatment, the patient would be on the high level, okay, of psychological well-being. Now, after the orthodontic preparation, there is a decline in the psychological well-being of the patient. Now, 1 week after surgery, the patient is already on the low side of the psychological well-being. After 6 weeks, there is an increase in the psychological well-being of these patients. And we, as an orthodontist, as I said, we see the patient around 4 to 6 weeks following surgery. So thankfully, when we see the patients, they are on the high end of the psychological well-being. The adaptation of patients towards these major changes, because the appearance, you change major changes in the appearance that would impact on the patient, okay? Now, it has been shown that older patients or individuals, they have more difficulty to adapt to these changes as compared to younger individuals. Now, there is a psychological adjustment period following the surgery, and sometimes the surgeons, they would blame it on the short-term use of steroids in order to reduce the swelling that happens after surgery and the withdrawal from these short-term drugs. So again, the orthodontist would see the patient when they are on the high level. Now, what about when we compare these cases to patients doing plastic surgery or cosmetic surgery? It has been shown that patients having orthognathic surgery seem to have fewer post-operative problems than patients having plastic or cosmetic surgery. For the following reasons: usually orthognathic surgery patients, they receive more support from their friends and family than do the plastic and cosmetic surgery patients. Usually the orthognathic surgery patients, they are referred for treatment as compared for those doing plastic or cosmetic surgery where they go individually, they want to do some corrections. Again, the adaptation in younger individual is extremely better than older individuals. Now, what are the reasons for dissatisfaction of patients doing orthognathic surgery? We can divide the factors for dissatisfaction into patient-oriented, surgeon-oriented, and patient-surgeon or orthodontist-oriented factors. When we look at the patient-dependent factors, it can be multiple or serious psychological problems. These psychological problems, they have to be identified before the patient goes into treatment from the beginning, okay? Unrealistic expectations by the patient, external reasons for surgery. So the interviewing of the patient and discussing the treatment plan is extremely important. You should have a committed patient because this is not an easy procedures to be done. It is major. Usually we don't sell the procedure to the patient. We let the patient buy the procedure. So we don't try to convince the patient, no, you have to do the surgery. No, you have to do that. No, you let the patient decide on his side, okay? Give the patient time to think, okay? Know and understand the expectation of the patient, what exactly he or she expects out of treatment. Motivation, okay? These patients, definitely they have to be internally motivated, which means that they are willing to do the procedure and the treatment. If they come under pressure from colleagues, from friends, from family, that you have to do a procedure, which we call it external motivation, then this could be a source for dissatisfaction. The surgeon-dependent factors: lack of empathy for post-operative problems, too little pre-operative preparation. So the surgeon, they have to sit with this patient a couple of times before surgery, discussing everything, all details of the surgery. The surgeon-patient interaction: poor communication or personality conflict, prolonged orthodontic treatment following surgery. Also, this could be a source for dissatisfaction. Post-operative neurosensory disturbances. Sometimes when they do mandibular procedures, the surgeons can accidentally touch a nerve, okay, which causes numbness in the lower lip region. Usually you have to calm down the patient. This would disappear in 6 months, okay, the numbness. So nothing to worry, reduce the anxiety level in these patients. Now, at the end, I would like to acknowledge the maxillofacial surgeons who helped and did the surgeries. Professor Nasser Noor, Dr. Muhammad Al-Kindi and Dr. Waleed Abdullah, and also the residents who were part of the team, Dr. Abtisam Al-Yazidi, Dr. Shuruq Al-Hassar, and Dr. Khulud Al-Shnefi. Thank you very much for your attention. Thank you.
Thank you very much, Dr. Nabeel. Have a seat, please. Any questions from the audience? Any questions? Yes. You have full on. It's fine. It's fine.
Does it work? Thank you for a great presentation. I have a question. Recently in the orthodontic literature, there's been some articles. Can you hear me okay? Thank you for your presentation. Recently in the orthodontic literature, there's been some articles on surgery first. I was wondering if you can comment on that.
Thank you very much for your question. I don't know if I get your question clear. You mean without doing orthodontics?
Surgery before orthodontics.
Before orthodontics. We don't recommend that at all, okay? Now, some surgeons, they get excited when they see these cases and they get in doing these procedures for them without having orthodontic treatment. So we don't recommend that for the following reason, that you have to align the teeth. You have to help the surgeons to do a proper movements of the jaw, eliminate the interferences, arch coordination. So if the surgeon goes in without orthodontic treatment, pre-surgical orthodontic treatment, then the results won't be guaranteed.
No, I guess the only reason why I say that is because the Koreans are the ones that have done a lot of these. They've shown that if you do surgery first, you could actually shorten the length of treatment for about 6 months.
Again, we recommend doing orthodontic, pre-surgical orthodontic treatment. I know it's out there. Okay, some people do that, but really we don't recommend. Maybe these cases are mild cases, but especially in those kind of severe skeletal deformities, you have to do a pre-surgical orthodontic preparation. Yeah.
Any more questions?
Thank you for the wonderful presentation. I want to find out the role of the orthodontist in surgical relapses. For example, if in case of bilateral sagittal split osteotomy, when you have the muscle action maybe causing a relapse, what's the role of the orthodontist? How can that be managed without surgery? Can that be managed without surgery?
Thank you very much for your question. Relapse is part of our life, okay, and it's a natural thing, and we expect relapse to happen, whether in these orthognathic cases or in regular orthodontic cases. The role of the orthodontist is quite big in managing relapse, okay. First of all, the orthodontist would continue with the patient, okay, following up the patient in terms of wearing the retainers. You have to put the patient under a follow-up program following debonding. So you would see the patient 1 month, 3 months, 6 months, and then every year. And usually these patients, they require fixed retainers. They would require something removable. Now, sometimes skeletal relapse would happen. Now, the retainers, long-term retention for the dentition would take care of the dental relapse. However, there are also chances for skeletal relapse. Usually the surgeons, they would go in, if it happens, they would do a revision. It's similar to the nose, okay? Some patients, they would do a rhinoplasty first time, and then they would do a revision second time, okay? So it depends on the type of relapse that happens, okay? Now, it is recommended to do some overcorrection. And as you can see, you saw in those cases that I showed you, usually the surgeons, they would really set back the mandible, they would give some overjet, okay, giving a chance for some future relapse. Thank you.
Thank you, Doctor. Any more questions from female side? Okay, thank you very much, Dr. Nabeel, for your very informative lecture and sharing us our first international conference. And on behalf of the scientific committee, We are giving you a certificate of appreciation, and inshallah we're going to see you again in our city and our conference. Thank you very much, Doctor.